Good morning, and welcome to the AAPOS 9th Annual Kushner webinar, entitled Glaucoma and Strabismus, a Tangled Web. It is an honor to be the moderator of this remarkable session and be accompanied by such accomplished and world-renowned speakers. The webinar is a collaboration between the University of Wisconsin and AAPOS. My name is Hilda Capó, and I am a pediatric ophthalmologist and service director at the Bascom Primary Eye Institute at the University of Miami. I would like to give you a little bit of history of how this webinar came around. So in 2015, when Dr. Burt Kushner retired, an endowment was created by the University of Wisconsin to fund an annual named lecture in strabismus or pediatric ophthalmology. The speaker is chosen by a committee consisting of members of the Pediatric Ophthalmology Service at the University of Wisconsin and a representative from AAPOS. AAPOS then provides the webinar platform, and the University of Wisconsin provides the honorary for the speaker and a bronze medal that you will see. So today we have 3 speakers in addition to our distinguished medal recipient, who is Dr. Sharon Freedman. Each speaker will give a 10-minute talk, starting with Dr. Velez, followed by Dr. Jain, and then Dr. Dagi. We will conclude with Dr. Freedman's 25-minute presentation. After the presentations, Dr. Kushner will make some comments, so stay on so that you don't miss his remarks. After that, we will have a Q&A session and a live discussion. So please send your questions to the Q&A feature, and I will relay all those questions to the speakers. Keep in mind that the chat will be disclosed, so the questions need to be sent through the Q&A feature. So I think without further ado, we will start our session with Dr. Federico Velez. He's clinical professor of ophthalmology and a Learner App Endowed Chair in Pediatric Ophthalmology at the Stein and Doheny Eye Institute, University of California, Los Angeles. Dr. Velez will speak on managing strabismus after sclerobuccal and special considerations. Welcome, Dr. Velez.
Good morning, Dr. Capó. Thank you very much for your introduction. I want to congratulate Dr. Freedman. She's been a role model, great mentor, colleague, and friend. Congratulations on your lecture. These are my disclosures. I acknowledge that I received grant from the RPV to do research on fibrosis of the extraocular muscles and scar tissue formation after surgery. Incidence of sclerobuccal and strabismus after 6 months, what we call persistent, is probably less than 5%. Risk or predisposing factors include reoperations, history of strabismus and amblyopia, extraocular muscle disinsertion, and macular disease. There's no really correlation between the position of the sclerobuccal and the type of buccal. However, there is a higher incidence of diplopia and strabismus when the buccal is repeat and in patients with implants versus exoplants. These are the mechanisms that I will briefly discuss. Conjunctival muscle tightness, like this patient with limited elevation on the left eye and limited down gaze on the right eye, tight conjunctiva tendons, and extraocular muscles. Fat adherence syndrome. Superior oblique entrapment, as depicted in this video, which is nasal to the insertion of the superior rectus muscle, impeding down gaze and causing limited abduction. Muscle weakness. This is a patient with limited elevation and a disinserted superior rectus muscle. This mechanism is being reported by Wu et al. At UCLA and Dr. Metz, following hydrogel sclerobuccals. This is a patient with a pull into medial rectus during a sclerobuccal implantation on the right eye. This video was taken 2 days following the procedure. Sensory factors. These are very complex because these can really impede the ability the patient has to fuse and see single vision. And this may include metamorphopsia, anisoconia, anisometropia, and well described by Dr. David Guyton drug phobia syndrome. I want to refer to this figure from Dr. Holmes and colleagues while he was at Mayo. And this describes very well patients with binocular fusion, patients with central diplopia and peripheral fusion, central fusion and peripheral diplopia. These two are described as retina misregistration, and this is a patient with diplopia caused by strabismus. The importance of this is that whenever we manage patients with scleral buccal diplopia, and we cannot obtain a stable good fusion on free space prism, we should do a cyanotophore examination. And this is very helpful, again, from Dr. Holmes and colleagues, that this cyanotophore can depict an area in the periphery where patients cannot fuse. And this is retinal misregistration. I think this is also very important, as described by Dr. Guyton, a patient that is corrected with trial frame prisms, and when the lights are turned off and the screen is switched from black and white to white and black, then the patient can fuse and the diplopia resolve. The light on test is definitely very important. Treatment options. For those patients that have central peripheral rivalry type of diplopia, non-surgical treatment options should be considered, including Fresnel prisms. This is also important for those patients who had true strabismus diplopia, and you can correct it with the Fresnel prisms, and then you can determine if the patient has true or not central peripheral diplopia. Bangerter filters and occlusion. There is also some report that if a patient has an associated epiretinal membrane, removing the membrane can improve the chances of fusion in about 40% of the patients. But there's also report that there is a 20% increase on chances developing new diplopia. Chemodenervation, there's some reports in the literature by Dr. Alan Scott, Dr. Buckley at Duke University, and the Morphle group. And you can see that there's about some good fusions in the papers by Scott and Dr. Buckley. The people at Morphle with a larger group of patients found that with one injection, 30% of the patients were able to fuse. It's been my experience that when I operate on patients, the rectus extraocular muscle depict a very interesting anatomy. Even though the muscle have not been disinserted, there is like a second insertion, frequently more posterior to the spiral of Thielow. And we actually presented a paper at AAPOS years back where we found that about almost 70% of patients with scleral buccal surgery who did not have the muscle disinserted show an insertion of the extraocular muscle more posterior to the original insertion. It is like if you did a pharein operation and you have a second most posterior insertion. Interestingly, this did not correlate with the alignment of the patient. Like this medial rectus muscle never operated on before is about 10 millimeters posterior to the limbus. What about scleral buccal removal? The scleral buccal removal alone had not demonstrated to help patients to improve and may increase the chances of retinal redetachment. This is a patient with a very anterior scleral buccal and limited elevation. Now, this is a patient that I recently saw. She had a scleral buccal placed in the left eye, and she developed diplopia. She also had intractable increase of her intraocular pressures. She underwent a scleral buccal removal, not because of her double vision, but because of the pressure. And as you can see, her double vision and alignment improved in those cases where she was really compromised. You can still see her limited down gaze, especially in abduction in the field of action of the left inferior rectus muscle. Removing the scleral buccal is being reported to help with the outcomes, and one of the advantages is the use of adjustable suture. This is a patient from my practice that had the scleral buccal removed. Partial removal, as depicted on this figure presented by this author, also reports to help with the outcomes and the use of adjustable sutures. This group of authors did not report any retinal redetachment. I always recommend to explore really well. Look, this is a patient that I was planning to operate on the superior rectus muscle because of a limited down gaze. And I went to look at it. I found this cystic mass near the superior rectus muscle. There was silicone on the anterior chamber. This cystic mass was silicone. Extraocular muscle surgery. I just want to say that it's important to consider where to put the muscles, but using hand-back techniques is being very useful. Dr. Capó and her group at Bascom Palmer reported excellent outcome by hanging the muscles over the scleral buccal. It's my preferred technique, when possible, to place the scleral buccal, the extraocular muscle between the scleral buccal and the sclera, because that's the anatomical insertion of the extraocular muscles. I can hem back and I can do adjustable sutures. Whenever you have a superior oblique entrapment, it's very important to reposition the tendon. You don't need to take the scleral buccal down. You can desinsert the tendon, pass it behind the scleral buccal, and come forward and put it back on the sclera. This is a paper that we did with the ACP analysts at UCLA, and we found out that risk factors for success in patients with strabismus and scleral buccal include less deviation and less restriction on the force duction testing. There was no correlation with operations on the contralateral eye or removing the scleral buccal. And this is a paper from Morfels, where they found that worse binocular outcomes are seen in patients with multiple retinal reattachment surgeries and sarcal elements, macula of RD, and patients that have central retinal dysfunction. In summary, persistent diplopia and strabismus following scleral buccal is infrequent. It's very important to determine if there is sensory limitations for the patient to fuse. Use the Synophthophore lights on and off test. Scleral buccal removal alone is probably not enough and may increase the risk of retinal redetachment, and hem back techniques are useful, safe for treating these kind of patients. Thank you very much for your invitation.
Thank you, Dr. Velez. That was an excellent presentation and an excellent review of patients with strabismus after scleral buccal. Remember, send all your questions to the Q&A feature, as we will be having a live session at the end of the presentation. So we're going to move on to our second speaker, who is Dr. Saurabh Jain. Dr. Jain is Associate Professor in Ophthalmology at the Royal Free Hospital in London, University College Medical School. Dr. Jain will speak to us on strabismus in orbital fractures. Welcome, Dr. Jain.
Thank you very much, Dr. Capó. Thank you very much for the panel members for inviting me to speak, and congratulations, Dr. Freedman. It's a real honor to be here, part of such a distinguished panel. I'm going to talk to you about strabismus following orbital fractures. I have no disclosures. So the things I would like to cover in the next 10 minutes would be, why do these occur? When do they occur? What do they look like? When they should be treated, and how they should be treated? What determines the outcome? And if we have time, maybe some cases to represent this. So we know there are two proposed mechanisms as to why orbital fractures happen. Either it is the transmission of the hydraulic force through the eye and the extraocular contents to the orbit, or it is the transmission of forces along the inferior orbital rim to the bones. What we do know that the floor is the most likely to fracture because the bone is the thinnest, especially in the posterior-medial part, and also there's minimal support from the underlying maxillary sinus. So who tends to get orbital fractures? Well, this is the largest study I could find, over 16,000 facial fractures over 10 years, over 60 hospitals in Germany, and they had a median patient age of 42 years. A large proportion of these fractures occurred between 16 and 35 years in young males, physical assault being a common cause, something we all see. 62% were combined, while only 38% were isolated. They found CT scan to be the gold standard investigation, and they used polydioxanone mesh or titanium to reconstruct the orbit. So what about the double vision? Well, we know quite a large proportion will have double vision at presentation, but significantly quite a large number will continue to have double vision after surgical repair. The most important prognostic factor for who has double vision post-op is that they have double vision pre-op. So if you have double vision pre-op, you are 3 times more likely to develop double vision post-operatively. And again, the site of the fracture really matters. So if you look at the image on the right-hand side of your screen, you can see the areas C1, A1, and S. And when you have a fracture here, then you're much more likely to develop double vision up, and the odd ratio is about 3 times. Okay. So why does it happen? Well, the two various the two cohorts of patients, one in where the problem is a direct damage to the muscle. It can be neuropraxia immediately following the fracture that gets better. It could be direct damage to the muscle from the traumatic event or muscle ischemia, or even muscle damage during the reconstruction surgery. And this is more a paretic group. Okay. And then you have a restricted group when the problem is in an adhesion between the muscles or the extraocular tissues, fibrosis, or again, entrapment by the plate. So you get two separate cohorts of people who get strabismus following orbital fractures. Now here's a patient, even my retinal colleagues could figure out that the extraocular muscles had been involved following orbital fracture. And that thing you see, that tissue jutting out, is the inferior rectus that's been transected. So there are two very distinct group of patients that we see who have strabismus following orbital fractures, those who have paresis and those who have restriction. And then we have a small group of mixed mechanism fractures. We know that this table could be taken straight out of any textbook that talks about differences between restrictive and paretic strabismus. Restrictive strabismus is usually straight or hypertropic in primary position, where the up gaze is restricted, the saccade is normal until it comes to an abrupt halt, the IOP rises in up gaze, the globe retracts, and the FDT will confirm. Whereas paretic, usually these patients are hypertropic because the IR is the most commonly affected muscle. So because of the damage to the inferior rectus, the eye is hypertropic. They have hypermetric saccades. The force reduction test is negative, but a force generation test, which I find very useful, which is essentially just a cotton bud dipped in anesthetic placed against the conjunctiva, and you're comparing the normal motility to the eye with the reduced motility. So you can have somebody with orbital fractures following orbital fracture strabismus present with a hypertropia, or even orthotropic with a condition only appearing in up gaze, and then any of them can have horizontal strabismus associated with this. This is a paper from Ramesh Kakunaya's group, which looked at 347 patients. And interestingly, they found exotropia to be the commonest kind of strabismus following orbital fractures. And I think part of the reason for this is because of the associated optic nerve trauma and the sensory exotropia, but also hypertropia and combined deviations. Interestingly, 80% had pre-op diplopia and 15% continued to have it. So it's really important, I find, when you operate on somebody like this, to set very realistic expectations, to have an in-depth consultation before. And what we're aiming for here, to have a diplopia field in the central and down gazes. We find the field of BSV very helpful to measuring functional visual area before and after, as well as Hess charts. So because we have two different mechanisms of fracture, we have to use two different ways of dealing with that. So the problem is the restriction of the muscle. Initial recession is helpful, but the problem is the paresis. You can recess the paretic muscle or resect its antagonist. And let me show you some examples. So this is a very typical case of a patient with a right enophthalmos and limitation of up gaze, which you can see, and following a right orbital floor fracture. Okay. Now if you look at the motility, you can see severely restricted in up gaze, so which is where the problem is. And this is what he looks like. The measurements, he's not too bad in primary gaze. He's got a small hypertropia, which really increases in up gaze. You can see the motility. Force reduction test is positive for a right inferior rectus. So we do a right IR recession. Now, the only problem with doing this is it's very possible when you do the right inferior rectus recession, you do improve the up gaze, but you can give them a reversal of strabismus in down gaze, which is a problem for two reasons. Firstly, it's a strabismus that they did not come with. Okay, so, and secondly, it is in down gaze, which is down gaze is where we spend most of our time. And this can be really disabling for the patient. So again, you have to warn the patient this might happen, and then this can be cured by matching the limitation on the other eye by using an inferior rectus technique, limiting technique, which might be a Fardens or a Scott stripe procedure. This is another patient. He has is a lawyer. They're always lawyers, and had a ski accident, right-sided facial trauma, orbital floor fracture, but also quite a significant neurological injury with the cerebroarachnoid hemorrhage. This was all resolved, but has left him with the right esotropia and a right hypertropia. So you can see here, he's got a significant right esotropia, and it seems to depend upon which eye he fixes it, and fixes with the Paretic eye, you can see the deviation is much more in primary gaze. So this is primary versus secondary deviation. And although the Hess chart looks quite restrictive, this very much is a paretic kind of problem. His FDT was negative for the medial rectus. So I carried out just a single muscle recession, and he responded really well to this. Of course, this is not enough. He still has limitation of abduction in right gaze, and we will have to consider what else we do for this. This is a paper by Burt Kushner, which looks at patients who had both restriction and paresis. And these patients had a very limited field of BSV. And Dr. Kushner's group carried out a simultaneous recession of the ipsilateral SR and IR, and you can see the significant change in the field of BSV. This really is my last slide. We have so far talked about releasing the restriction and making primary gaze better, but we cannot forget the gaze where the deviation is the most. So whether that be up gaze or abduction, and transposition surgeries can really help. They can be full thickness, and you can see here the initial description when the augmentation is by linking it to the sclera, or the Buckley modification and link it to the muscle. You can use a Nishida procedure when you're just pulling the muscle bellies to one side using a suture. And the advantage is you're not disrupting the ciliary supply of the anterior segment. You can carry out the crouch type procedure when you do MR recession and a full thickness transposition just for the superior rectus, the posterior fixation suture. And I quite like the NAPS procedure when you move both the horizontal recti superiorly, because it can improve elevation, but at the same time, you can deal with any associated horizontal strabismus. So this just is a bit of a schematic for what we've been talking about, and I'll be very happy to take your questions at the end. Thank you very much for your attention.
Thank you very much, Dr. Jain. That was excellent. And you have some sub cases that we would definitely like to discuss a bit further in the Q&A session. So I would like to introduce now Dr. Linda Dagi, our next speaker. She's a director of adult strabismus at the Boston Children's Hospital and associate professor of ophthalmology at the Harvard Medical School. She will speak to us on strains from fusion to diplopia with glaucoma, the cost of fixation switch, suppression, and visual field loss. Welcome, Dr. Dagi.
Thank you very much for the opportunity to join this session, and congratulations, Sharon, on this great award. Let me go ahead and share my screen. And can you all see that? Great. So we're going to speak now on straying from fusion to diplopia with glaucoma. And we're going to emphasize in this talk the cost of fixation, switch diplopia, suppression, and visual field loss. But first, I'm going to give a few slides on new onset diplopia in association with glaucoma more generally. In fact, the most common cause is mechanical strabismus, as you might imagine, related to glaucoma drainage devices or blebs. There's a mass effect from the implant or associated bleb, which may cause strabismus and diplopia. You can have scarring, fat adhesion, or incorporation of adjacent extraocular muscles within these devices. Supratemporal implants tend to cause hypertropia and exotropia, sort of pulling the eye up and out by scarring. Supranasal implants, in contradistinction, more frequently cause hypotropia, I think because there's simply less room in the supranasal fornix. It abuts the nose, and there just is less room for the eye to move. Approximately 50% of those with diplopia from this have a torsional component. It's typically excyclotropic, often thought to be due to damage to the superior oblique or scarring in this area. Here, courtesy of Pavlina Kemp, one of our former colleagues and now at Iowa, is a nice image of a supranasal implant causing hypotropia and exotropia. You can see this large Ahmed Satan valve with a giant reservoir bleb adjacent to it cause the eye to go out and downward. In a case of my own, I had a young adult with congenital glaucoma. He had failed angle surgery in the first months of life and had bilateral Ahmed valves placed supratemporally. He did well for a short period of time. The left eye did well for life, but the right eye failed over time with loss of IOP control. He had multiple procedures to follow. A Baerfeld 250 placed infranasally because the superior fornix was taken. There with a corneal half moon. Then he had cyclophotocoagulation and the Baerfeld placed infratemporally. So now 3 major devices around this right eye. And he developed, not surprisingly, a large restrictive hypertropia due to supratemporal scarring around the Ahmed valve and insufficient space for the eye to infraduct due to both Velez. He had mechanical restriction of adduction as well. So what about treatment of mechanical strabismus? It's really on a case-by-case basis in these patients. You'll need to consider dissection of scar tissue around the implant, but there's a lot of considerations here that are a little different than around buckles. If you're lucky, you can reduce mechanical strabismus sufficiently without altering intraocular pressure or invading the space around the implant or the bleb. If you do, there's always a risk of hypotony or elevation of intraocular pressure due to effect on the valve or the bleb. There's also an increased risk of anterior segment ischemia. These patients have had a lot of surgery around the limbus. You know, we think of anterior segment ischemia due to too many eye muscles being operated on, too many rectus muscles, but it can happen from significant dissection around the limbus of the conjunctiva. There's a risk of endophthalmitis if you invade that space around the bleb. There's a violation in a sense of the intraocular space. It's best performed with the co-surgeon, the glaucoma specialist who placed the implant, because they know the anatomy best and they can have a plan and help you with preoperative planning for options for intraocular pressure control. And you have to consider ahead of time whether you're treating diplopia or just strabismus without diplopia, because in some cases, perfection is the enemy of good if you really do not have a diplopic patient. And if the mechanical strabismus is modest, I've often managed this problem by performing surgery on the contralateral eye that might lack a bleb or a device because the risk is lower and you may be able to successfully achieve your goals. Diplopia in medically and surgically treated patients with glaucoma is not that uncommon. Jonathan Holmes' group did a look at 195 adult glaucoma patients treated surgically and medically, some without surgery, and they had them complete a diplopia questionnaire. 21% had diplopia, a very large number. Binocular diplopia was present in about 1/4 of patients who had had a glaucoma drainage device and 3% of those who had had a trab. Hypertropia was most common. Monocular diplopia was also a problem, mostly because of corneal problems, but sometimes because of field loss. But I want today to discuss a different issue. I want to focus this talk on binocular diplopia not due to surgery, because it's often found in these patients, though a smaller percentage, of those with treated glaucoma without devices or trabs. Why does binocular diplopia occur? And how might this impact your choice of surgery and whether you operate? So let's move on to binocular diplopia associated with glaucoma not due to surgery. And we're going to do this with a little trip around the world rather than looking at, 9-position charts, but talking about examples of how this occurs. We're going to talk about how to understand the less obvious causes of new onset diplopia, which are actually very challenging to recognize and to treat, and especially challenging to recognize when there's a mixed mechanical mechanism, as well as these other mechanisms we'll learn about. We'll talk about fixation switch diplopia, which occurs in cases where you have a previously suppressed eye, so childhood strabismus, and now the suppressed eye has better central acuity. And we'll talk about diplopia, which occurs because of visual field loss, confusion, loss of fusion, and secondary strabismus. What causes fixation switch diplopia? What actually is it? First of all, you need a history in almost all cases of childhood strabismus with a suppression scotoma in the non-dominant eye. For example, a case of congenital esotropia with amblyopia. Fixation switch diplopia occurs if there's a change in ocular fixation preference. It's most commonly seen actually after cataract surgery if it's performed on the non-dominant eye first, and the post-op acuity in that non-dominant eye exceeds that in the dominant eye. But it may occur with bilateral glaucoma in a patient if the previously non-dominant eye becomes the better eye, as seen in cataract surgery. Why? Because the previously dominant eye doesn't have a suppression scotoma. We don't know how to turn it off. So here's an example on our trip around the world. Mrs. Johnson has medically controlled glaucoma. She has minimal field loss. She has no history of childhood strabismus, and she's touring Turkey along the Bosphorus. And so this is what she sees looking out her window from the boat, a beautiful view. Her binocular visual field is the sum of the monocular fields of her left and her right eyes. She fuses nicely. There's no diplopia and she enjoys her trip. And you can see the field of the left eye, the field on the right, now fused together, no problem. She continues her travel to a film and dance festival in the high Chilean Atacama Mountains, where she sees these beautiful dancers. Now she has company. Her travel partner, George, also has medically controlled glaucoma, but he is different. He has a history of infantile esotropy with suppression of the right eye, and therefore a smaller horizontal, quote, binocular field, because he's really looking out of his left eye. Mrs. Johnson has a wider visual field. They stay in Chile for a year, and George stops taking his medication. He develops significant vision and visual field loss in his left, previously dominant eye. That previously dominant eye declines, smaller field, blurred vision. His previously suppressed right eye now becomes the dominant eye. So then what happens? He has fixation loss diplopia with glaucoma and intractable diplopia, along with this field loss. So you can see he has a double image of these two dancers. Now there's 4 dancers, and he cannot fuse them together, and he cannot turn off his previously dominant eye. So fixation switch diplopia after cataract surgery is a little simpler. There's no field loss. Here we have it the more typical way seen with glaucoma. How do you treat this? Well, unlike after cataract surgery, you're less likely to restore ocular dominance to the primarily dominant eye, because in the case of cataract surgery, the surgeon will typically go on and perform cataract surgery on the previously dominant eye. It becomes the primary fixing eye and the problem is resolved. But this is not often a possibility in our glaucoma patients, because the previously dominant eye has now lost vision permanently. You can attempt prism correction before considering surgical correction, and I would suggest that, because if with prism correction you can get the patient to reasonably comfortably fuse the images, it's possible that using prism or doing surgery will succeed. However, in many of these cases, the image may float and slip after such surgery, and you need to warn the patient about that. And monocular occlusion may, in fact, prove necessary. However, fortunately, most patients do not have a history of childhood suppression and strabismus. But in the case of glaucoma and bilaterally significant glaucoma, field loss may also result in diplopia. How does that occur? If you have insufficient overlap in the remaining visual fields to maintain fusion, you can develop diplopia and image slip. So now Mrs. Johnson, George, and the family depart Chile for India. They're visiting the Taj Lake Palace in Rajasthan. It's a beautiful view out their window. Mrs. Johnson's enjoying this gorgeous view of these towers. George is using monocular occlusion. He has not yet seen his ophthalmologist back in the States, and he has to occlude one eye to prevent diplopia. George's brother has also come along, and he has glaucoma as well. He has end-stage glaucoma with visual field loss with altitudinal hemianopia in both eyes. Fortunately, there's some overlapping intact visual field, and this helps to prevent image slip. So the top of the tower is still connected to the bottom of the tower, and although he has a limited field, he has a pretty nice view. However, over time, several months later, his glaucoma worsens. Perhaps his compliance with medication was also not great, and there's now minimal overlapping of the intact visual field. There's no way for him to connect the top of the tower to the bottom of the tower. Over time, he's likely to develop image slip, similar to hemifield slide, where the bottom half of the tower moves in one direction, the top half in another, and this can happen horizontally or vertically. So this is a case of advanced glaucoma with loss of motor and sensory fusion due to visual field loss. This can occur if you have severe visual field loss with insufficient overlapping visual field to prevent vertical or horizontal shift or slide of each monocular field. It's similar to the type of hemifield slide that's been described secondary to chiasmal lesions, for example, or other forms of optic neuropathy causing altitudinal defects. The phenomenon with this insufficient overlapping of visual fields to support binocular fusion has been well described by Jonathan Holmes and his colleagues, as well as Roper Hall. The treatment of this is more challenging even than in some cases of fixation switch diplopia. Usually monocular occlusion or blur is necessary, and you might consider the use of a min occlusion lens, which is a nice type of occlusion lens. It kind of looks like a dense Fresnel, but the view to the outside, from the outside observer, is that they can see the patient's eyes, but from the other side of the glasses, the patient does not see out. Prism correction of surgery is rarely useful or successful because the second image often floats or slides away. So this is just a brief look at the many causes of binocular diplopia in patients with glaucoma. You can see it for mechanical reasons, often associated with drainage devices or blebs, and you can see it for sensory reasons like fixation switch diplopia or loss of visual field. And in many cases, there is a combination of the two. And so you need to think carefully before you proceed with strabismus surgery. Make sure your plan's a good one. Thank you.
Thank you, Dr. Dagi. That was great and very interesting concept on the sensory aspect of why we can develop strabismus after glaucoma surgery. I just want to remind our audience that we have the Q&A feature that we should use to ask questions to our panelists. We're going to have a great live session at the end, so please submit your questions. I think we're going to move on to our next speaker, Dr. Sharon Freedman. And first, I would like to congratulate her for such a well-deserved recognition. As we know, Sharon is amazing. So I'm going to go a little bit over her bio so we can all learn a little bit more about Sharon. So Dr. Freedman was born and raised in Durham, North Carolina. She attended Duke University, and then she went to Harvard Medical School. She did an ophthalmology residency at Mass Eye and Ear and completed 2 fellowships, a fellowship in pediatric ophthalmology at the Boston Children's Hospital and a glaucoma fellowship at the Duke Medical Center. She started her career at UNC Chapel Hill and then joined the Duke Eye Center, where she's currently a tenured professor of ophthalmology and pediatrics. She's chief of the Pediatric Ophthalmology Service, and she's a fellowship director. Dr. Freedman is well-versed in all aspects of pediatric ophthalmology, but she has particular interest in pediatric glaucoma, pediatric cataracts, and retinopathy of prematurity. She has published almost 250 peer-reviewed articles, participated in multi-center clinical trials, such as the IAPS and the PEDIC studies, and has mentored numerous trainees. Her work with AAPOS has earned her the Lifetime Achievement Award, and she has served on multiple committees, being chair of the program committee, a member at large of the board of directors, and she's been president of AAPOS. She's not only successful academically, but she has a very rich personal life. She and her husband, Neil, have 2 children and 3 healthy grandchildren. She loves to bake. She loves to be a grandma. She loves to travel and to do work outdoors. So it is an honor to have Dr. Freedman with us here today and deliver the 9th annual Kushner webinar. She will be talking to us about, sorry, her talk is...
Strabismus and glaucoma, no worries.
Okay. Well, we're going to move on. Dr. Freedman, please go ahead.
Welcome to the 9th annual Kushner webinar. Dr. Burt Kushner needs no introduction, but I can't resist providing a few details for our younger listeners. After earning his MD at Northwestern, Dr. Kushner completed residency at the University of Wisconsin and fellowship at Bascom Palmer. He returned to join the faculty at the University of Wisconsin, becoming the John W. and Helen Doolittle Professor, and now Professor Emeritus at that same Waukee institution. A very brief summary of his prodigious academic accomplishments includes the publication of more than 200 papers, 41 textbook chapters, and 3 books. He has delivered at least 30 named lectures and was editor-in-chief of AAPOS and the New Journal of AAPOS. He's currently editor of the Journal of Binocular Vision and Ocular Motility. His awards and honors are too numerous to name, but most notable is his continuing selfless dedication to his patients, trainees, peers, and our profession as a whole. Although I never had the privilege of formally training under Dr. Kushner, I was always struck by the clarity and humility with which he has delivered invaluable data-driven clinical pearls to us through his spoken and published works. One of the wonders of AAPOS meetings for me was the honor of meeting this giant in our field and discovering him to be wonderfully approachable and genuinely interested in advancing my career and that of other newbies. Thank you, Dr. Kushner, for the honor of delivering this year's Kushner Lecture. I join a list of previous lecturers who are more creative and innovative in strabismus than I. When Burt found me at last year's AAPOS meeting and honored me with this invitation, he suggested that I might speak about strabismus, which brings me to my topic, the interface between strabismus and glaucoma. I have no financial disclosures. Strabismus and glaucoma are diagnoses with an intertwined complex relationship. Glaucoma often exists along with strabismus in adults and children. Surgery for glaucoma, especially glaucoma drainage devices, which I'll call GDDs, can cause or worsen strabismus in those with glaucoma. Conversely, surgery to improve strabismus in patients with glaucoma can actually worsen glaucoma control, especially if that surgery involves a GDD device modification or removal. And sometimes we can combine strabismus and glaucoma surgery when they both coexist preoperatively. Finally, glaucoma surgery can sometimes be affected by prior strabismus surgery, and adaptations are needed. Strabismus is common in children with glaucoma and is often sensory, usually ET or XT, and often coexisting with amblyopia and unilateral or at least asymmetric glaucoma. These children are usually not binocular, and surgical intervention is not always needed. We examined our own childhood glaucoma patients for strabismus some years ago, and of 62 kids with primary congenital or glaucoma following cataract surgery before getting a GDD, 17% had horizontal strabismus, 3 with a vertical component, and all had full eye movements. In a later study of 81 children at Duke with refractory glaucoma of all types prior to their first GDD, a full 47% had any strabismus. Strabismus surgery in these cases should be performed sparingly and always aware of likely future glaucoma surgeries. Fornix surgery is preferable, helping us spare superior and limbal conjunctiva and stem cells. For eyes receiving a superior temporal GDD, especially a Velez, it's reasonable to combine lateral rectus muscle surgery with the GDD surgery because it will be harder to get to that lateral later. In this case of exotropia and glaucoma following cataract surgery, we see a Velez 350 implant, which has been placed superotemporal. The lateral has been secured with a suture and is being disinserted and then reattached to the original insertion. The forceps on the right is actually holding the inferior wing of the Velez, which has become unstable with removal of the lateral. Given the large size of the reservoir, an additional suture was needed to stabilize that inferior wing, and the lateral was then allowed to hang back over the plate. I don't now prefer that technique because the capsule over the inferior Velez wing often appears very prominent without the muscle over it, as you can see in the bottom photo of this child who had this very surgery. There's always a chance that the recessed lateral may not adhere well to the plate, which has to form a capsule over it at the same time the vicryl on the muscle is getting weaker over the first month. My current preferred approach in these cases, which I now always do through Fornix, is to plan how far back the lateral will be hung and then trim a corresponding amount of the anterior portion of the inferior Velez wing so the lateral rectus hung back from its original insertion will now contact the sclera in front of the plate. And although you lose a bit of surface area from the GDD, the resulting appearance and stability are very good. A recent publication by Jacobson and Bonesack describes yet another option for combined Velez and lateral rectus recession, tilting the Velez 350 plate backwards behind the recessed lateral. This worked well for these authors, but a caution is to make sure the eye is long enough to avoid GDD contact with the optic nerve. Here's a link to a short eye formula we developed, and I'm happy to send it to you separately. As you've heard from Linda Dagi, adults with advanced glaucoma have lots of reasons for strabismus and diplopia, even without glaucoma surgery. Usually in these cases, there's decreased vision and visual field in one or both eyes. The diplopia is often intermittent and can sometimes be dealt with conservatively and using Fornix surgery if strabismus surgery is needed. The true incidence of diplopia and strabismus in adult glaucoma is difficult to determine, as most studies don't address these issues before the GDD with full sensory motor exams or even a standardized diplopia questionnaire. Diplopia seems to be present in up to 10% of adults with glaucoma before GDD surgery and any surgery, and strabismus in up to 28%. But perhaps more interesting and more problematic for sure are those patients who come to us with strabismus and diplopia, which occurred or worsened only after intervention for their glaucoma. While most glaucoma surgeries never or rarely directly cause or worsen pre-existing strabismus, GDDs are often to blame. Strabismus has been reported after GDDs of all types, placed in all quadrants and with myriad resulting patterns. Many mechanisms have been proposed for the strabismus after GDD surgery, including mechanical from a large bleb, a posterior fixation Faden-like effect, especially with larger DDB plates and double plate devices, increased muscle length when the plate is under the muscle, and displacement of the superior oblique tendon with superior nasal GDDs, causing a Brown-like syndrome. Fat adherence and even direct muscle injury have also been proposed. Combinations of these likely exist in any given case. Here are some of the more commonly used GDDs. Of these, the Ahmed FP7 and Bearville 250 and 350 are the most commonly encountered in the US, although the clear path on the right is becoming more popular. It's worth noting how long these plates are from front to back, especially if you encounter them during strabismus surgery. The true incidence, as mentioned, of strabismus after GDD surgery is tough to quantify. Often glaucoma surgeons who work primarily with adults seem surprised when a patient complains of diplopia after their surgery. Underreporting of post-GDD strabismus is common, especially since many children and even some adults don't complain about double vision. Notably, a prospective study of strabismus in adults as part of the tube versus trabeculectomy study randomized adults with glaucoma to either a superior temporal 350 Bearville or mitomycin C trabeculectomy. They compared strabismus before and a year after the GDD surgery. Note that 70% completed that one-year motility exam, and of those, 23% had poor fixation and were evaluated by Krimsky. As I mentioned previously, a surprisingly high percentage had strabismus before the glaucoma surgery, 28%, and similarly in those who were going to get a tube versus a trab. Most of these were exodeviations, and very few had vertical strabismus. Diplopia was noted preoperatively in only a minority of these patients. New onset persistent diplopia occurred in 5% 1 year after the tube, but none at 1 year after trabeculectomy. And new onset motility or worsened strabismus occurred in 10% of the tube and none of the trab group. Strabismus occurring before tube surgery did not appear to change the risk of having diplopia after it. A recent non-randomized study had adult glaucoma patients having GDD surgery take diplopia questionnaires and noted post-GDD diplopia reported in 18% versus 5% after other glaucoma surgery. Note that not all the diplopia the authors felt was related to the GDD. Sun and colleagues similarly noted diplopia more common after GDD than trabeculectomy surgery, 23 versus 3%. By contrast, another large retrospective study found relatively low rates of new onset strabismus, 4%, and only 3% with diplopia after Ahmed GDD, most being exodeviations, and surgery was pursued in half. In our own patients with GFCS or PCG, we found strabismus was common after GDD implantation, increasing from 17 to 40% horizontal and 3 to 21% vertical strabismus, with 30% showing a motility limitation, which was usually vertical. In a larger review of 81 children at Duke having primary GDD placement for glaucoma who had both pre and post-GDD motility data, we found that 47% requiring a GDD already had strabismus, and after GDD placements, 31% had new or worsened strabismus in primary gaze. 40% had a new motility restriction after the GDD, which was often vertical. We were unable to find specific risk factors such as age or type of GDD placed. The pattern of strabismus also changed from mostly XT and ET, which you see in the left, before GDD implantation. And on the right, for those 25 patients with new or worsened primary gaze strabismus, there was a prominent vertical component as shown by the red blotches. Similar findings were noted in a small cross-sectional study by another group where they had 90% with some motility limitation. Now, considering what to do with strabismus after glaucoma surgery should consider the severity of symptoms, the risk, feasibility of interventions, and the alternatives. The choices include no treatment or occlusion of one eye, prism for primary gaze or reading, and surgery, which may attempt to avoid the muscles adjacent to the GDD if possible. A small surgical series co-authored by our Dr. Velez addressed the challenges of treating diplopia after GDD in adults. Most of these were superior temporal Ahmeds, and most of the deviations were exodeviations. The authors noted modest success. They eliminated primary gaze diplopia in 5 out of the 9 and improved it in another 3 out of 9 cases, with procedures which included capsule excision in 6 and plate removal in 1 case. They stressed the need for a glaucoma expert to assist here. Another series co-authored by our moderator, Dr. Capó, addressed outcomes of surgery per post-GDD strabismus over 13 years at one institution. This retrospective study included 16 patients, 9 of whom had diplopia. Most were adults, most had exodeviations, and 2/3 of the plates were supratemporal. Most of these were Baervelt 350s. The authors favored surgery on the eye with the GDD, but attempted to avoid entering the capsule over the GDD and had only one inadvertent capsule rupture. About 50% had classic motor success with resolution of diplopia in about half. We examined outcomes of strabismus surgery for childhood glaucoma patients having had GDD surgery, as well as those having concomitant strabismus and glaucoma and GDD surgery, and identified 25 patients at Duke. 15 had strabismus surgery together with GDD implantation, and another 11 had surgery after GDD placement. Ahmed's and Baervelt's were evenly split. Most cases were GFCS and PCG, and only one patient had preoperative diplopia. In the 14 cases having GDD and strabismus surgery together, most were for exodeviation and involved recessing the lateral rectus by hangback. The mean pre-op deviation was 28 prism diopters and improved in 80% of cases, but only 29% achieved standard criteria for motor alignment. In the 11 cases having strabismus surgery after GDD, there were a variety of patterns with improvement in 2/3, but no cases meeting strict criteria for success. We found no clear relationship between GDD model or size or magnitude of the starting deviation. We had no unintentional capsule rupture. Now let's consider the surgery itself. After Ahmed GDD, adjacent muscles can usually be approached and managed by a fornix approach with care to avoid rupture of the capsule where possible. I used the microscope for these cases. This 80-year-old man with POAG noted worsened exotropia after a Baervelt 350 in both eyes, and he insisted on surgery despite the absence of diplopia. He had full eye movements, and we planned a, quote, simple R&R in his non-dominant right eye. Again, this was done under the microscope. 4 suctions were done. Traction suture is placed. You can see the plate already supratemporal. I prefer an infratemporal fornix approach and expect lots of bleeding and lots of adhesions. Remember, he's 80. We're being very careful with the conjunctiva. First, we're going to try to dissect over the plate and over the muscle. And now we're going to try with a catina to isolate the muscle at its insertion. Remember, it's lying directly over that capsule and over that plate. It's often necessary to purposely split the muscle and then add parts. So first we're going to address over the muscle, and then we're going to start working under the muscle. I like to cauterize him carefully. We're trying not to cut muscle, but we also don't want to cut the capsule. That white thing is the inferior wing of the plate. This was just a precautionary para because we hoped not to open the capsule, but we weren't sure. Again, careful dissection, careful cautery. Finally, we'll be able to verify that we have that muscle separate from the capsule. And now we will use the usual technique, 6-0 vicryl. We will take the lateral off, and then we will hang it back. And I like to measure the amount of hang back, as you'll see, taking it off. It's good to have a glaucoma or a surgeon or to be ready yourself if you're familiar with these devices, to expose and tie off the tube if you should get a large capsular rupture. We did not, fortunately, in this case, so we're going to reattach the muscle to the original insertion, measure the amount in a moment of the hangback, and then simply push it back. Here the capsule is already formed and the lateral will certainly adhere to wherever it is put. So here we're measuring the large recession, and then we're going to simply push it back, and then I'll close that incision with a running suture just in case. Here was another case. This 6-year-old boy had glaucoma after cataract surgery. He had microcornea, and his mother reached out to me by email asking for help. He'd had an FP8 put in, which controlled the glaucoma in his left eye, but the mother didn't like the way it looked. This eye had poor vision. It had a reasonable pressure. It was stuck in adduction, and the bleb actually touched his aphakic spectacles. He could not fully close that eye. In this case, we knew we were going to be removing that plate. We knew we'd be rupturing the bleb. First, So here we're making paracentesis. We're putting viscoelastic in. We plan to do an endoscopic cyclophotocoagulation as well because the pressure was just barely controlled despite medications with this large bleb. So now we're going to open the bleb and that eye will decompress itself. There it goes. And now we will tie the tube off by backhanding a 6-O-polygalactin suture, tying the tube off. And now we will do further dissection, get that plate ready to remove and clean it up. And now we are going to do endoscopic diode cyclophotocoagulation, which unfortunately you can't see in a separate screen. And now we're going to actually be prepared to take the tube out in a minute. And I'd like to close this by a mattress suture of 8O Vicryl on a vascular needle over the tunnel. And that avoids having to dissect to the limbus. And then we'll close the incision. This child actually did very well. He had full eye movements after the surgery. He did well for a number of years without a GDD, which his parents desperately didn't want. Here's another case. This young man with glaucoma following cataract surgery had Ahmed GDD supratemporal in both eyes. He required ECP in his right eye and then a Barevelt 250 infranasal in the right eye. He did well for a number of years until I put an infranasal Barevelt in his left eye, and unfortunately his small XT with alternating hypers turned into a large XT and LHT, and he did not like the way it looked. Our plan was to do ECP first in the left eye, then to explore and remove the infranasal plate and do medial rectus resection as well. I think you can see the large exit deviation. You really cannot adduct or infraduct that left eye. So here we are preparing. We've put a traction suture in. I like to use traction sutures at the limbus. Force suctions are definitely positive to depression and adduction, which we anticipated. We are now going to make a fornix incision about 8 millimeters back and expect quite a bit of scarring here. Our goal is to first find the tube. Again, I don't dissect to the limbus here, just find the tunnel over the tubing and open it. And then we will backhand a 6-O polygalactin to ligate the tube, just as we did in that previous surgery. We're going to ligate that tube because we know we're going to have to cut it later and we don't want to empty the eye when we do that. We're going to anchor it to nearby tissue. I call this like a double mustache, and that way the tube won't come out, hopefully until we're ready for it to, despite our manipulations. I've had the tube go into the eye and come out prematurely as well without this technique. Paracentesis, because we know we're going to need to fill that eye. Now we're going to dissect over the plate and then open the capsule. It won't empty the eye because we've ligated that tubing already. And now we're going to recheck to see if just emptying the bleb was enough to resolve the force suction problem, which it wasn't. So now we're going to dissect to expose the plate. Remember that at each fenestration, there is a tight attachment from below the plate to above the plate, and you can't get the plate out if you don't cut these. Even the anterior positioning holes often will get this tissue in them. So we have to cut every one of them. Now we are still going after them. Now we're going to cut the tube right in front of the plate. It's secure in position. Now we're going to flip the tube over, the plate over rather, and you can see you have to get those very back fenestrations, and finally the plate comes out. Force suctions are now better, not perfect, but better. So now we're going to do some dissection. We need to find the inferior rectus and clean it of attachments, which I've edited out a bit to save time. And now we're going to find the medial as well. With the medial safely secure on a hook, we're free to go after the rest of the capsule, or at least most of it. It's very important to realize that you're going very far back here. We can usually prolapse the capsule forward, sometimes snapping it to be able to cauterize it and let the back part just go back out of the way is advantageous. We're going to let that go. And then we're going to find that medial. Now, isolating the medial is always a little harder in these cases. There's some adhesions between the surrounding tissues and the muscle. So we're going to go at it. Sometimes, as I've mentioned before, it involves splitting the muscle and then adding little parts to it until you get all of it. I always prefer that to causing damage inadvertently. And now we've got that muscle on a hook. And now we're going to clean it off and resect it. And then we're going to reattach it at the original insertion and tie it back in place. And now I had intended just to look at the tube. We're going to cut the suture holding the mustache. And while I was doing this, oops, it came out. So no problem. We'll fill the chamber with some air. And now we are going to put that mattress suture of 8-polygalactin on a vascular needle to close the tube tunnel. No need to dissect forward toward the anterior chamber. It's much easier to stay back in these cases. So we're going to tie that off nice and tight. And then we have a watertight situation. Force flexions are much better. And now we are free to close the tenons and the conjunctiva. You never know when you're going to need them later, so double closures are always my preference. This patient did much better. He was satisfied, not binocular, but able to look down and in much better than he did before. Finally, let's consider GDD surgery in eyes after strabismus surgery, because we've encountered a few of these and wanted to know how commonly they occurred. We found 17 eyes receiving a Behrvelt GDD surgery after prior strabismus surgery, and of these, 4 had a prior rectus muscle recession that affected the planned Behrvelt. 3 were laterals and 1 was a medial. And here's our technique for handling these. And this was similar to what you saw when we were doing a Behrvelt and a lateral rectus at the same time. This child had already had a lateral rectus recession and now was going to get a Behrvelt. The lateral was supposed to be back 7 millimeters. We're dissecting forward here in preparation for that Behrvelt going in. We hook the superior rectus, as is my usual, and then we're going to hook the lateral. And we found the lateral, in this case, recessed, and we found it back 15 millimeters. So figuring how far back we wanted the plate to be, that 15 millimeters is how far back the lateral was. We figured that we had to trim a portion of the anterior wing. We decided to trim 5 millimeters off. It was a long eye, so we could put it 9 to 10 millimeters back from the limbus, that is the plate. Be sure you're trimming the inferior wing. And so we trimmed it, and then you'll see that it fits very nicely behind that recessed lateral rectus. The cosmesis is nice, and we've not done a randomized controlled study, but we found usually that our control of the pressure is still adequate after this technique. We're going to put it in. And you still have to taco it in a bit. In my adult colleagues' cases, I have asked them, often they don't really notice and they just put the plate in, but then sometimes they're under the superior, over the lateral, and really don't like that technique. So there we go. So in summary, strabismus commonly occurs in glaucoma patients, and GDD surgery can exacerbate the problem. Patients and parents should be informed of the motility risks of GDD surgery. Strabismus surgery can be safely performed in eyes after GDDs, but with modest success. GDD surgery can be safely performed in eyes after strabismus surgery with adaptations. And glaucoma surgery for refractory glaucoma cases must balance the efficacy of GDDs with their risks to motility and binocular function, and hopefully we'll have better techniques in the future. Thank you for taking your Sunday to listen, and have a wonderful day.
Thank you, Dr. Freedman. That was really fascinating. I think those videos just illustrate how difficult those cases can be. They're really, really challenging. I think compared to other cases that we do, strabismus cases, these are probably the most challenging ones, the ones that have barbell glaucoma implants in them. So we're gonna have the Q&A session in a little bit. Please feel free to keep on sending us questions. We'll have a very interesting live discussion. But before we go ahead with that, I would like to introduce Dr. Burt Kushner, who's gonna give us some remarks. Welcome, Dr. Kushner.
Thank you, Dr. Capó. And I'd like to congratulate and thank all of the speakers, Drs. Dagi, Velez, Jain, for 3 fabulous talks. And of course, thanks to Dr. Capó for moderating. And a special thanks to Dr. Freedman. it's hard for me to believe, but this is the 9th lecture in this series. Time certainly flies. And I would say everyone has been better than the preceding one. I had high expectations for this year's lecture, and Dr. Freedman certainly exceeded those expectations. I knew she would do a fabulous job. I'd also say I really have, she has my admiration for tackling these very, very difficult and challenging cases. So as the recipient of this award, Dr. Freedman will or has received the medal. This is what it looks like. On one side is a likeness, and on the other, the emblem of the great University of Wisconsin. She will also be getting the promised honorarium. I would also say that there have been 9 recipients now of this medal, and my understanding is not a single one has ever contracted COVID while wearing it. So I'd encourage her to wear it and with happiness and to stay well. I also want to thank AAPOS and Ashley Kronstead for co-sponsoring this lectureship. It's been a wonderful ride so far, and I want to thank the viewers for tuning in. And with that, I will turn this over to Dr. Capó, unless I see Sharon came on. If you want to say anything, Dr. Freedman.
Well, Burt, I'm just extremely honored, humbled, grateful to be able to present the talk. It's a little bit unnerving when you talk, because I don't consider myself a giant in strabismus at all. But then the more I thought about it, we've had some strabismus with our glaucoma. So thank you for the opportunity. Thanks to my co-speakers. We thank you, Burt, for leading us, for teaching us in such a humble and yet instructive manner, always with data, always with humility. We hope to carry on that tradition. And as we noted, we want to leave plenty of time for questions and answers. So I do just want to show that the actual medal is even nicer. So there's Dr. Kushner in the front, and there's the emblem of the University of Wisconsin. And I would have worn it during my talk, Burt, but it was going to hang sort of out of the field of view unless I went too far back in my office. So thank you so much. And we'll open now to Dr. Capó, who's going to lead our questions and answers. Burt, thank you again, and congratulations.
And thank you.
So I would like to ask all the panelists to go ahead and turn on the videos and unmute themselves so that we can start with the Q&A questions. Thank you, Dr. Kushner, for everything. And again, Sharon, it was an amazing presentation. So let's go ahead and get started. I think when we look at the questions we have, one says this is probably for Jain. For restricted strabismus following orbital fracture repair with orbital implant, what factors determine if the implant needs to be removed?
I think that's a great question. I think it also depends on what type of implant they've had. So we used to have a lot of titanium mesh implants, and they are a real problem to deal with because they cause a lot of fibrosis and adhesion. So even if you want to, I think you struggle to remove them. I think things are a bit better because now we have specially molded orbital implants. So I think what would lead me to ask the maxillofacial surgeons to remove an implant would be if you had immediate worsening of the diplopia or causing of strabismus after the implant was put in. So if you had a clear evidence of entrapment, that's when we would ask them to look at the implant position. A lot of the times I have to say, they say, no, the implant is fine. And then I think we deal with the motility problem as we see fit.
Okay. There's another question for Dr. Jain. It says, I think with blowout fracture and torsion should be ruled out. Any comments on this? Sorry,
so the question is torsion should be, I think torsion should be ruled out in any kind of restricted strabismus, to be honest. And we are very lucky in the UK that we work with an excellent orthoptist. So I really insist on all my patients, but especially all my incompetent patients, to have 9 gaze measurements on the synoptophore, ideally, where torsion can be measured. So absolutely, torsion should be ruled out.
Yeah, they want to know if you have encountered in torsion and how have you managed it?
So I have to say I haven't, because It's maybe just the cohort I've seen. But again, it's like no, I think as I was saying, firstly, we have to determine, is it a restrictive kind of strabismus or a paretic kind? And then depending on the etiology, then I would look at the torsion, whether it would be a nasal transposition of the inferior rectus or moving the inferior oblique or whatever. I think each case is so different. So you just have to look at the etiology and then the kind of torsion.
Okay, well, thank you. So we have a question for Dr. Dagi. It says, is there a way to diagnose fixation loss diplopia, or is it based purely on history? How do you diagnose the fixation loss diplopia?
It's really largely based on history. It occurs in patients with a history of childhood suppression and amblyopia. It's almost impossible, at least I've not seen cases of fixation loss diplopia in the absence of that history. So it stresses the importance of getting the history of strabismus in childhood. You're probably not going to see it in a patient who had an alternating intermittent exotropia, but it's more in your patients who had maybe like a congenital esotropia with amblyopia and suppression. Sometimes these patients come to you and they have this really traumatic strabismus, and it all seems to be related to the implants and something else they've had. And there's almost an ability, and their vision's not so great in either eye. And it's very easy to forget to ask about their childhood history. I also think that I'm sure there are cases where there's a combination of mechanical strabismus and strabismus related to visual field loss, fixation, switch diplopia, and the kinds of techniques you use to resolve the mechanical strabismus may not be sufficient because of the kind of image slip you might get or inability to fuse the remaining image. Oftentimes, you can get some sense of how well the patient will fuse by using a synoptophore or using prism, but I would say that in general, just as with more routine adult strabismus patients, sometimes that underpredicts the number that will maintain comfortable fusion. And many patients are willing to proceed with surgery if the strabismus is significant to see if they can. Some may end up in some form of occlusive lens to follow.
Thank you. Next, we have a question with Dr. Freedman. Thank you for a wonderful talk. And do you have any tips for hooking the muscle in the presence of a glaucoma drainage device?
Yeah, work under the scope, be careful. I have the pleasure or the displeasure of having to take care of the tubes myself because I sometimes caused it, and my glaucoma colleagues are not going to come in with me because they know that I put them in as well. So the key is that it is wrapped, and especially the Bearville, it's wrapped around the capsule. It's entirely fused to that capsule. And so I use a really narrow hook. I like a Katina, but whatever you like that's narrow. And I just feed the muscle insertion or wherever the insertion is. I think, Federico, like you mentioned in buckles, that where you actually get your hook under is not always going to be at the stated spiral of Thiebaud location. Usually it's a couple millimeters back, and I just slip a little more muscle and a little more muscle and a little more muscle. It's actually pretty hard to penetrate the capsule intentionally, except when you're dissecting between the muscle and the capsule. And so that's why I sit there with a hook on the lateral and kind of go under it and scoot right up to the underbelly of the lateral, cauterize, snip, 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 snip. And then once I get 2 hooks under, now you can sometimes sort of peel that muscle off. In a case where the eye is moving fully, and this guy had terrible glaucoma. I mean, he just didn't like the way it looked, the elderly man that I showed. And there was no way that I was taking out his plate for him. And I don't think that's what caused it. It just, his forced sections were free. Where the forced sections are really involved, and Federico and his colleagues, did do a lot of dissection of the capsules. That's a different story. So I think, Linda, you sent me a little message saying, Saurabh, you sent me a message saying, how the heck do you get that lateral off? If it's tight, I mean, you just literally got to scoot in. That's why I spent a few minutes showing that video, because it's painstaking, it's bloody, it's pain in the neck. I don't ever adjust those. I just hang them back somewhere and then deal with other muscles. Generally, if they're not diplopic, it's great. They just want to look better. And if they're diplopic, a lot of times, as Linda said, you can go for it. But even the best experts in Hilda's group and Federico's group, had modest success by the usual criteria. And so I think you just have to be very honest with these people. Yes, we can make your eye look straighter. We can make it move a bit better. Are you still going to have some double vision if you have it now? Absolutely. But we'll try.
Yeah, I think I have had similar experience as you have, Sharon. I think muscles are frequently scarred down to the implant. But I do what I do with retinal detachment patients as well. That sometimes the muscle is scarred down to sclera anterior to the buccal. So sometimes I just go further, more posterior than what I think I'm going to hook the muscle, and I don't necessarily dissect the anterior portion of the muscle.
Exactly.
I just work the muscle there. I leave the scar, I separate it from the capsule, free the muscle completely, and then let it hang back.
Yep.
So you don't necessarily have to dissect all the anterior aspect of the.
Right. No, literally our dissection was just to be able to lift the muscle off at all. We were definitely not trying to get all the way to the original insertion.
You
So
know,
if
Hilda,
you'd like to share some of your experience with this kind of patient, because you have published on this.
Sorry, did you ask me?
And if you want to share some of your experience with the
No,
glaucoma.
I don't have any
Yeah,
more things to
published.
say. I will say that I love a technique that I learned from Dr. Rosenbaum, and I think he learned from Jan Polsky, called the tunnel technique, but maybe Dr. Kushner knows who published that technique. I think it's great to dissect these muscles under the sclera. I was always concerned that Dr. Rosenbaum was going to go inside the eye because he had took those Westcotts and go under those muscles, but honestly, I think that's the only way to dissect these extraocular muscles, in my opinion. I also want to mention that just be very careful if you have a history of a patient with retinal detachment that had a vitrectomy, because I have seen vitreous coming out of those previously sclerotomies. So, and not directly from trauma from the surgery itself, but just the pressure, I guess, and dissected too much. So other than that, I think Sharon did a marvelous lecture. There are a lot of questions, but it's more like the cases are so difficult that we should send them to her, and that's it. Simple, but very good. Thank you.
so I have a few thoughts. One, I wanted, the tunnel technique is a really interesting one. We have found, at least in Boston, that we hang back the sutures right over the buccal. And, when I started doing this, I was terrified the muscles wouldn't adhere to the globe, but they do. And I think it may be potentially technically easier to do than the tunnel technique. It's amazing how the muscle finds its way back to the eye, even though it's the vicryl. And we're not even talking about, using Merceline. The vicryl is literally hanging over the buccal. One other thing about buccal cases, if you see a buccal that's really tight on the eye, just like sometimes it can cause elevation in intraocular pressure. The other thing it can cause, as you've indicated, Federico, indirectly, is scleromalacia. And if the buccal's removed, sometimes you'll be staring at uvea. So it's just another one of the thoughts about these buccal cases and about this question of incyclotorsion with orbital fractures. We've seen a couple of cases and reported on a couple of cases where a plate is placed that extends from the medial wall through the floor, and the inferior oblique is essentially disinserted at its origin to place the plate, and they get essentially an inferior oblique palsy. And you can treat that very effectively with a contralateral superior rectus recession, because essentially the inferior oblique has been disinserted with the placement of the plate.
Can I just say one clarification? I was referring more to the tunnel technique, not to place the extraocular muscle, but it's to dissect the muscles of the sclera.
Okay,
Yeah.
right.
So it's just to clean the muscles to be able to at least detach the muscle.
Sure.
Absolutely.
Yeah, you have to make sure the muscle is free, but I do what Linda does. I just hang it over the buccal. I don't create a tunnel underneath the buccal for the suture. And I do the same thing for the glaucoma implants. I just hang it over, and as Linda mentioned, it's impressive how they always find a way to stick back to the globe. If anything, we have more undercorrections and overcorrections when the surgery fails, indicating there was not a slip muscle.
Or it may be attaching to the capsule over the bare belt in that case. But if you cut those capsules, most of them feel like sclera anyway. So it's certainly a secure location for that muscle to be.
Yeah. There's a question asking if you notice more strabismus with barbell as compared to AMED implants.
That's to me, I assume. And the literature is all over the place. I think on the one hand, I like that the AMED doesn't take up it doesn't go under the muscle insertions, then it's a heck of a lot easier to get back to them. So if I have a, strabismic younger patient, older kid who needs a tube, and I think the Ahmed will do it, I would actually prefer not to put in a bare belt, but but it's really more to get back to the muscle later in case they need strabismus surgery. That's why I hang back the lateral at that time if I'm going to put in a bare belt. But I don't think the jury's out on that. The Ahmeds have a higher profile, and there are some studies retrospective that tried to blame Ahmed more than bare belt. In your study, Federico, most were Ahmeds. In yours, Hilda, most were bare belts. In my experience with children, certainly infronasal, I've been burned both ways with an Ahmed and a bare belt 250. I don't have the guts to put in a 350 except in a totally monocular ophthalmic eye, which I've definitely done in kids. What amazes me is when we don't get strabismus, not when we do. Same as buckles. I'm always amazed how most people do tolerate it as opposed to that they don't. But I don't think the jury's out on that. I don't think there's any good data. Our study of 81 kids who had good motility data before and after, our numbers weren't big enough. And even though I was sure we were going to find one or the other, but we didn't. So I think it depends is the answer. Depends on the kid, on the size of the orbit, on the size of the eye, so on.
There's a question here that in patients that have strabismus surgery before, and we need to implant a glaucoma drainage device that will interfere with a new insertion of the muscle, choosing a device that is not so wide, can it be an option?
Absolutely. Yeah, no, definitely. That kid that I showed you where we were putting a 350 bare belt in, we could instead have put in an Ahmed, or even, you can put a 250 bare belt, which really doesn't interfere very much with the muscles. And honestly, a lot of our adult glaucoma colleagues, the patient's awake, for heaven's sakes. You think they know for sure where they're putting those plates of the bare belt? I'm certain that often they are over one, over the lateral if it's been recessed and under the superior. I don't like the way it looks. And if you really have the muscles hooked and you can watch it, you find out that it's just not that stable, and it really doesn't look that good if there's not muscle in front of it. But yeah, absolutely. You could put in an Ahmed or even trim the whole wing down, and you would still have a reasonable surface area for the bare belt.
So Sharon, what is the biggest disadvantage of trimming the wings of the implant?
It's the theoretical possibility that you get less pressure control, and I really don't think there'll probably never be a randomized controlled study. I just think if you think about the surface area of the whole 350 and how much you're taking off, and I'm not mathematically smart enough to figure that out, but I'm guessing you're taking off less than probably taking off 20% of the total surface area of that plate. So I trim plates all the time in little kids anyway, because the axis length's not long enough. So it's just the theoretical disadvantage that you'll get less surface area for the filtration. That's it.
Okay, we have a question here that probably for the whole panel. Is it used for or indicated to operate a patient with a terminal glaucoma with a residual visual field who has esotropia to do the surgery for cosmetic reasons only?
I'll go first. I maybe had in my slide, double vision is better than no vision. And I will show those their visual fields. And if I think I'm going to take a risk and have to go around a trabeculectomy, we didn't even talk about that, staying the heck away from those. And, I've turned patients down, frequently turned patients down and say, look, I know you're not happy, but you have some vision, you have a blinding disease, your disease may blind you. I don't want to speed that up. Here's your occluder, or buy yourself some shaded glasses if they don't like the way it looks, unless we can think of a really safe way to do it. But if I'm going anywhere near their devices and they're not controlled, or they have just little tiny islands like Linda showed, and sometimes they literally, here's a hint, when you can't do alternate cover tests because they can't find the other target when you cover one eye, they could probably live the way they are. I don't know about my other colleagues.
Well, I think the surgery they really want it. I do warn them of all the risk involved. And if it's a very large angle, they prefer to do surgery. They prefer to deal with a double vision. They prefer to take the risk. That's been my experience. But that's why I want to get the comments from the rest of the panelists.
I guess it depends a little bit on the quality of the vision. You might, first of all, choose monocular surgery, so you're only taking a risk in one eye. It's one thing. It depends on how likely you think the vision is going to be lost altogether in the contralateral preserved eye. I suppose it depends a little on the age of the patient, how many years in front of them. Is this a 20-year-old or a 60-year-old? And you might choose to do something that is far less perfect, but make things better. Like with this massive esotropia, you can just disinsert the medial rectus. You don't necessarily have to place sutures or adjustable sutures or all these other things that, more dissection. You could do something more minimalist. You're never going to resolve diplopia in those patients anyway, but if they look better, it might be an option.
I found another option is to use toxin. It can be a really good temporizing measure in these patients, because obviously it's the least invasive thing you can do. And again, it won't be perfect, but at least it's not very invasive. And if they don't like it, well, it's going to go back to the original angle.
Do you find that toxin works when there's a lot of scarring?
It's variable. Usually not, but if it depends again, as you were saying, so much on the patient and what they want, and if we can get them a little bit better than what they arrive with, and then they can make a judgment call. Well, we can have this non-invasive procedure; it'll be 50% better, or I can have a proper operation. And you say it's so difficult.
And Saurabh, have you ever put it in a lateral over a Bearveld?
So yes, I have, and
Wow.
it was, and I spoke to my glaucoma colleague before, and they were very relaxed about it. They said, well, if you puncture the capsule, it only improve the drainage. I think they were just saying that to make me feel at ease. But yeah, it worked. It worked. It was
Cool.
not something.
That's a neat idea.
I think, as Sharon, you mentioned before, that capsule tends to be thick. It's not that easy to perforate it.
It's not that easy. And if you've done,
It was very fearful when I did my first cases, and
absolutely,
really happen. I always get a backup just in case, make sure somebody's around.
absolutely.
Especially just in case we get into trouble. But and I want to mention that it is a lot thicker and less more difficult to really perforate than what we think.
Very good point. And if you do bleb needling, you find that, because you actually, even with the needle, you have to enter that capsule and you kind of feel that resistance. So I think with experienced folks like we have on this panel, that's not going to happen accidentally. But for some of our colleagues who may be doing this for the first time, it's just handy to be a little cautious.
Sharon, you made a reference to the difference in the fibrosis. How do you consider the risks of working around a trabeculectomy versus an implant?
Oh, I mean, I think it's a big difference. I'm extremely concerned about those, especially thin trabeculectomies, and you'll occasionally encounter a patient with double vision. Usually it's one of our colleagues has done a trabeculectomy revision. So, they was leaking and they took a whole bunch of the superior fornix and they pulled it down, and now the patient can't look down very well. And I hate those, because, I think the patient needs that trabeculectomy typically. They're very hard to make happy. I have gone in with a colleague and went up into the fornix and just tried to release it at the fornix, not touching the revised bleb at the limbus, and didn't do as much as we wanted it to. Working around a tube, unless you rupture the capsule or you take the tube out of the eye accidentally, which you're not going to do, you're really not going to hurt the way that thing works, whereas with a trabeculectomy, anything you do to incite inflammation or, heaven forbid, make a hole in it. If it's one of these thin, long-standing blebs, that's the difference between the patient having a pressure of 8 and seeing their teeny little island and not being able to do that. So I think we can be much more, not cavalier, but much more forward about or flexible about going around GDD plates than your trabeculectomies. I just stay away from them. I just will not go near them. I'll find something else to do in the other eye, the other quadrant, something like that. I don't know about you guys.
Hilda, may I mention something that I believe is in glaucoma, not in retinal detachment. So whenever possible, especially with advanced glaucoma, I really feel like it is important to determine if that patient will be able to fuse those visual fields. If you're not trying to correct an strabismus that is giving the patient better peripheral binocular vision, even though the patient may not have complete fusion. But those patients may develop secondary strabismus just to enlarge their binocular field of vision.
Yeah.
And there is a good chapter, even though it's not in glaucoma, it's more on neurological condition by Steve Kraft on Rosenbaum's book, that he actually, I try to always at least discuss with fellows. I think it's an important determination, because you may be happy with the alignment. The patient may say, I don't see double, but you will reduce significantly the peripheral vision of these patients when you correct the exotropias, and the patient may not like it, and this patient may have trouble functioning. And the second thing, just to mention, that I have found, I started doing this at Duke with Tanya Glazer, where we started managing patients with esotropia and glaucoma with supratemporal implants by doing a procedure just like just the Yokoyama. Just think about a Yokoyama for myopic strabismus. We start fixing the lateral rectus to the superior rectus muscle to fix those hypotropias and esotropias, and it worked really well without touching the capsule. Basically, you just put a suture between the lateral rectus and the superior rectus. I've done a few more cases here at UCLA, and it works beautifully. So I never go to the good eye. I think going to the good eye is not necessary, especially in restrictive strabismus at all.
Difficult to convince the patient to go to the good eye. So I think we're running out of time, but there's one more final question for Jain. Is like, how long do you wait after the floor fracture before you tackle the strabismus?
Thank you very much. So there's a really good paper by Piotr Loba and colleagues, and what they say essentially the first 2 weeks, of course, unless there's a risk to the vision, or there's a there's a big in ophthalmos that you usually shouldn't go in. For the strabismus, I like to wait at least 6 months, if not 12 months, because things continue to settle, fibrosis happens, adhesion happens. Really want to give it as long as possible. So I would say at least 6 months.
Good. Well, I think we're running out of time, so I would like to thank everyone, especially Dr. Freedman, for such a wonderful talk. All the panelists, it was super interesting, an amazing live session. I think we all learned a lot from this webinar. And of course, to Dr. Kushner for being the inspiration for all this to happen. And for that medal that will protect Sharon from getting COVID while wearing it. So Sharon, wear it as much as possible.
Absolutely. Everybody stay warm, and thank you all for your time on this Sunday, and especially thank Dr. Kushner.
Yeah, thank
You
you.
all.
So enjoy the rest of the Sunday. Have a great day.